Okay, in the trenches, we're going to talk about osteoporosis. This was the topic that was requested and made. This is an outpatient topic, and I often work with rheumatology and endocrinology on this. It's very common, more common in women than men. As a whole, average age, we start screening women at age 65, men at age 70. Unless they have certain risk factors or they have a demonstrated pathologic fracture. Okay, you basically, with osteoporosis, you have decreased bone strength and decreased mass. And age could cause it, but there are other things that cause it. So in a man with osteoporosis, premature, think of steroid use, hypogonadism, or alcoholic liver disease. Women who have osteoporosis, they're often thin, Caucasian, very slightly built, but there's so many exceptions to the rule, and we diagnose this with the DEXA scan. DEXA scan, you're looking at a T-score, which compares bone mass to that of a person at a younger age, usually a woman at a much younger age. If your T-score is -1 to -2.5, that's called osteopenia. If it's greater than -2.5, that's osteoporosis. And, you make the diagnosis, you have to ask yourself how you're going to approach this. And this is a common thing. And DEXAs are part of routine health screening in the office, just like a mammogram, pap smear, colonoscopy. So, treating this with osteopenia, you want to make sure the patient has enough calcium intake. And it's usually greater. As the older you get, greater than 1,200 milligrams. The younger age, greater than a gram. And it could be via diet. The more via diet, the better. You don't want to get higher than this. There was a debate whether it causes calcification in blood vessels. That's really super high levels of calcium. But often what you have is a patient on calcium, maybe a 500 milligram pill a day, and they substitute the rest with diet. Vitamin D, also check vitamin D levels. Most people I find have low vitamin D levels. You get vitamin D via being out in the sun. And with the replacement, if you have vitamin D insufficiency, you replace it with over-the-counter vitamin D. If you're just slightly below normal, maybe 1,000 to 2,000 national units a day. If you're really below normal, 5,000 units a day. You have to monitor it. They used to use 50,000 units of vitamin D, high dose, once a week for 3 months. That may or may not be changing. You have to be very careful that people don't overdose on that, because they can wind up with kidney stones. Then you talk about the medications. And really, the medicines are bisphosphonates, bezidenab, and anabolic agents. The bisphosphonates, first one was alendronate or Fosamax. Initially, we gave it every day. Now we give it once a week. There's some cousins of it you can get once a month. You have to take it with a glass of water in the morning and not take anything PO for 30 minutes afterwards. There are IV bisphosphonates, and the most common is alendronate or reclast. That can cause fever and reactions, but it works, and that's an option. A lot of patients are on that. Bezidenab or Prolia is an agent that is REC ligand inhibitor inhibits bone resorption. It's given subcu twice a year. It's commonly used, and sometimes it's used as first line because there are not too many side effects, and you take it twice a year. The problem with this, once you get off it, you need to get on something right away. Initially, people are only getting it for 1 to 2 years. Now you could go longer on it. I don't know if they have data post 10 years, but that's commonly used. And then if a patient has really, really low bone mass, especially with the pathologic fracture, you have uh, the anabolic agents, Forteo and Himlos. Or you could use Evenity, which is combination anabolic and inhibits bone resorption. So those are agents for very advanced osteoporosis. You'd be in them for a year or two, and then transfer either to Proly or bisphosphonate. Now, when you get a DEXA scan, you're really imaging. You're imaging the hip and the lumbar spine, both hips and the lumbar spine. And you can also be imaging the radius. Usually you worry about hip fractures, which cause a lot of morbidity and mortality. Lumbar spine, you get compression fractures and loss of height. As far as the causes, you will go through the causes. Often you don't find the cause. You have to rule out hyperparathyroidism, hyperthyroidism, steroid use, which is, in the history, and vitamin D deficiency severe, that could contribute to this. But you want to rule out secondary causes of osteoporosis. Often you don't find them, and the key is when you make the diagnosis, you treat them. Exercise also helps strengthen bone. Get them on adequate calcium and vitamin D replacement, and you give them the appropriate medicine. Sometimes with bisphosphonates, two side effects you have to worry about. One is osteonecrosis of the jaw, and that if somebody has cancer, those patients are more prone to that. Like if they have multiple myeloma or somebody's getting major dental work, you have to be really careful about the bisphosphonates. And the other, these fractures that are like mid-shaft femoral fractures that occur with bisphosphonates, and often, to prevent these, people are bisphosphonates for a period of time, and their doctors will give them a drug holiday. And that's basically this in a quick nutshell. Sometimes women are placed in a drug called raloxifene, not commonly used. It's a selective estrogen modulator. It's not used to be used more often. We're not using long-term estrogen replacement now. And I'm going to stop there. Thank you.